to ask any doubts in between also. The talk here is optimizing myometrial ultrasound imaging, a guideline-based approach. So examination of myometrium, if you look into the anatomical component, it is the muscle of the uterus. And through the day of the talks, we have seen how the genital organ anatomy should be scanned diligently with a dedicated protocol, and the same holds true. Obviously, when you do a protocol-based imaging, the anatomy stands out beautifully. So examination of myometrium, the aim is to detect, diagnose and distinguish. The first and foremost important thing each and every one of us is to be very familiar, very clear, confident about normal myometrium. Then you have all the time under the earth to distinguish and think about what the abnormality is. And the second most important thing I would like to emphasize is put the image in clinical perspective. What does this image mean to the patient? So with these two things in mind, you go ahead. The guidelines of examination of myometrium was introduced way back in 2015 as MUSA criteria, which means morphological uterus sonographic assessment. It is the terms, definitions and measurements. Essentially, they mean consensus statements to ensure uniformity amongst the inter-observer operators and speaking the same language. So the MUSA criteria, originally, this paper describes the terms, definitions and measurements to delineate the myometrial characteristics and abnormalities. These abnormalities, they have predominantly categorized focal lesions, the most common lesions fibroid. Second, adenomyosis. How to diagnose adenomyosis? What are the characteristics? This was in 2015. However, this 2015 paper did not discriminate between the adenomyotic lesions. It could detect, but it could not further refine what are the direct, what are the indirect signs. So this Delphi classification system in 2021 deals with recognizing and identifying adenomyotic lesions. However, still it did not propose a uniform single classification system for this disease. So here it stands regarding the imaging of myometrium. Now coming to the assessment modalities, TVS is and should be the first line of imaging because it gives you a detailed assessment of myometrium within a limited depth of view. See the clarity of the imaging, but the depth of view is limited. On the contrary, transabdominal scan gives you a global view of the uterus in pelvis and gives you a global picture of the relationship of the uterus to surrounding structures. So anything larger or beyond the true pelvis, you should resort to transabdominal imaging. And at this point, I would always emphasize, never hesitate to stop at the imaging because this is it. You should always take help of MRI in case the ultrasound doesn't suffice, because the aim is complete anatomical characterization before clinical decision is made. Now, what can you look into when you do a high resolution dedicated protocol imaging? So myometrium is the uterine muscle. Now this uterine muscle has got a characteristic signature pattern which you can recognize clearly, and that is the zonal anatomy of the uterus, meaning the structural components of the uterus here, namely the serosa or the bright layer of the peritoneum which covers the uterine myometrium all around. Second is the vascular arcade or the uterine vasculature which runs beneath the subserosal aspect. And and this uterine muscle is divided into two functional units which are delineated even on gross anatomical picture. The inner junctional zone or hypoechoic layer is the thick band of smooth muscle, circular layer tightly woven bordering the endometrial cavity. This is called as myometrial halo or junctional zone, and the outer myometrium is sparse in myometrial density and it appears mildly brighter. So this is the zonal anatomy of the uterus. This uterine anatomy should be 100% consistently identified by a beginner. The more and more you see, your eye will go towards picking up abnormality. So the layers of the uterus, can you do on an ultrasound? Yes, very well you can pick up on ultrasound. And the same zonal anatomy you can replicate on MRI. The strength of MRI is its beautiful tissue characterization, central bright endometrial, bordered by a thick junctional zone T2 hypointense, outer hyperintense myometrium, vascular arcade, and the serosa. So this is a normal uterine anatomy. Coming to the vascular pattern of the myometrium, the uterus receives its blood supply from the transverse cardinal ligaments, the uterine artery, which are the branches of the internal iliac artery, enter into the uterine parametrium and courses in a subserosal manner, that is the outer arcuate vessels, which are seen as a hypoechoic tortuous channels along the outer myometrium. And from this, perpendicular radial branches penetrate into the myometrium and reach up to the junctional zone or the inner endometrium. This vascular pattern is time bound, like it shows cyclical changes through the cycle based on the effects of hormones. So this is unique to female pelvis anatomy. Coming to the addition of 3D, three-dimensional imaging is a volume acquisition of sweep of the same uterus and then you render it in a three-dimensional mode. The strength of 3D is it will enable you for an offline examination, send sequences for a second opinion, and the third most important is you can slice it any plane. It will give you a coronal plane of the image which is equivalent to as you see in a laparoscopy. So that is the 3D imaging. Coming to the endomyometrial junction, this is extremely important. Previously it was brushed aside that it could not be picked up on ultrasound, but no, latest optimizational ultrasound techniques enable you to define the junctional zone with high amount of accuracy, even on a high definition 2D and definitely with three-dimensional TVS with VCIC mode. This junctional zone clarity is very well appreciated. So no longer you require an MRI to confirm a junctional zone abnormality. Definitely there is a role, but you can try and image the junctional zone on an ultrasound as well. See how it is, the junctional zone is a roadmap to the uterine pathologies from the endometrium to myometrium. So what is the relevance of the junctional zone here? The latest consensus and additions into MUSA guidelines look, do not measure junctional zone, look at the morphology of the junctional zone. It should be smooth band, very clearly marginated. Any irregularity and a normal, uninterrupted, smooth junctional zone all along, it's an indicator, high negative predictive value of absence of adenomyosis. So at the start, if you can establish a normalcy, you are good enough. Then what are the other significance of junctional zone? To look at the breach of the endomyometrial junction, which will give you a clue to the myometrial invasion in cases of endometrial cancers, and extension of myomata or submucous extension into the endometrial cavity. Also, it can give you the exact character of congenital uterine anomalies. So that is the importance of identifying and characterizing the junctional zone. Now next comes zoom out, uterine measurement, shape and external contour. So the uterus can be anteverted, retroverted, retroflexed. The most important thing, place the probe in the fornix, have a global view of the uterocervical length. Then the uterine corpus measurement should be done from the internal os to the fundus. Cavity is measured from the internal os to fundal outline, and fundal myometrium is A. So, and in orthogonal probe, turn the probe orthogonally at the maximum width, then measure the transverse and AP diameter, which will give you a estimate of the uterine volume or the bulk of the uterine muscle. Next comes the serosal contour. These are all the descriptors, terms and definitions as per Musa criteria. Serosal contour of the uterus is the tracing of the serosa along the uterine outline. The irregular uterus is defined as which is having a normal smooth serosal contour. This hyperechoic or hyperreflective peritoneal lining clarity is extremely important. A normal serosal contour can be seen in a normal uterus. It can be seen in uterus with small seedling fibroids which hasn't distorted the uterine serosa. It can as well be seen in focal adenomyosis involving anterior or posterior walls without involving the serosa. Or it can also be seen in diffuse adenomyosis with intact serosal contour. So the serosal contour of the uterus can be seen in normal or any pathologist which hasn't affected the outer serosal reflection. On the contrary, the serosal contour can be lobular, one secondary to myomata or secondary to any mass lesions indenting and disrupting the serosal outline. Then you look into the symmetry of the uterine walls. Anterior and posterior are normally symmetrical. You can have range of appearances, diffuse, globular, asymmetry between anterior and posterior walls, contoural asymmetry and distortion secondary to focal space occupying lesions. Once you define the nature of the lesion within, if it is a focal lesion, you have to comment on the lesion size, shape, position within the myometrium and the lesion-free margin or its relationship with the structural endometrium or to the serosa, and depth of penetration. The other parameters which you look into is the echogenicity. Normal myometrial focal lesions are categorized or graded based on comparison with the surrounding normal myometrium. Isoechoic, hypoechoic, hyperechoic. And then finally color Doppler, you assign a color score which is a subjective assessment of presence of color flow. Color score 1 means no color, 2 is minimal, 3 is mild and 4 is moderate.
Can you use the pointer to...
Okay, sure. Now we are coming down to Musa criteria. Two things I will be covering. One is myomas, second is adenomyosis. Myomas, as per the Musa terminology, they are well-defined rounded lesions within the myometrium or attached to it, showing shadowing at the edge of the lesion or shadowing in the shape of an internal fan or both. They can have a variety of internal echogenicity, circumferential flow around the lesion. And now you understand when these descriptors are seen, if you have a common terminology before, when there is a lesion, what is the size, where is it occupying, which topographic anatomical location is it, what is its echogenicity with respect to the surrounding myometrium. So those descriptors will come in play when you look into these abnormalities. So by definition, there are clear-cut established signs of atypical myomata, typical uterine fibroids. You can go through this in article. Now coming to practical relevance, fibroid mapping, ultrasound and MRI. I always include MRI because depending on the indication, you might need to choose MRI. What should be reported and how do we do it? Basically, when you have to look into the choice of the imaging modality, definitely ultrasound is the first line of imaging modality. TVS is more accurate than TEAS. Why? Because it delineates the structural components of the uterus with greater clarity. The relationship of the myoma to the junctional zone, the relationship of the myoma to the serosa, and the location within the myometrium. All those high resolution findings, TVS is more accurate. Color Doppler can be done in special cases. Saline sonography is used to diagnose submucosal fibroids, sometimes to distend the cavity and define extent exactly between the FIGO 0, 1 and 2. Now the role of MRI is large uterus. As we told, the limitation of ultrasound is machine field of view, small field of view. So whenever the uterus is large, more than 375 cc, or multiple myomas, more than 4, requiring an objective characterization of individual fibroid prior to surgical mapping, definitely you should refer for an MRI. Capacity of TVS for exact myoma mapping, whenever it is falling short, then MRI comes into play. And additional strength of MRI is it provides you signal characterization, meaning it will give you a macroscopic picture of the composition of the fibroid. So whenever you look into fibroid, you try to classify based on the location and its relationship to the structural components of the uterus. And the fibroids are classified into FIGO 1 to 7, and 8 is cervical fibroid. And intracavity fibroids are graded by 0, 1 and 2 depending on its entirety of extent within the endometrial cavity and the myometrium. And once it is a submucous fibroid, you have to give a Lasmar score. What are these scores intended for? They define or triage the patients for the procedural complexity, whether directly the patient will go for a myomectomy or they will consider GnRH before the surgery. So what are these scores? So you have to look into the size, topography of the uterine corpus, low, mid, up, extension of the base, the largest diameter of the fibroid and its relationship with the uterine wall, that is the attachment, because it decides the complexity of the excision, and then penetration and lateral wall involvement. So in essence, these are the checklist: number of myoma, size, site, extent, FIGO, least distance from the cavity, least distance from serosa, degenerative changes or calcifications if any, vascularization pattern, and if you feel that the ultrasound characteristics are not typical, you are not defining the edge shadow, you are not defining the internal shadow, the vascular pattern is too bizarre, it is not explaining the typical myoma characteristics, you resort to MRI to characterize the signal pattern to establish the benignity. So this is the checklist of the myoma mapping. So here 42-year-old female, menorrhagia, painful periods, hemoglobin 6 grams. So once you see the uterine anatomy here, this is the cervix, this is the outer serosal outline is very clear. The internal endometrial lining, I am able to trace it beautifully here. The endometrial lining along the posterior aspect, mid and upper body is interrupted by a well circumscribed space occupying lesion showing internal shadowing and edge shadowing. So the lesion is typical myoma, and the location of the myoma is posterior wall, upper body, FIGO 1 in extent, meaning more than 50% is intramural, but it is trying to enter into the cavity. And on vascular pattern, you can very beautifully define the pedicle and a circumferential flow around the myoma. And the same you can render on a 3-dimensional mode, and you can give a schematic representation for the surgeon to understand and decide for the surgery. And sometimes you can do saline instill the saline to enhance the imaging to better delineate the exact extent of the penetration of the fibroid into the cavity. So what is the role of MRI? MRI will exactly determine the same. It will tell you the site, size, extent, characteristics, degenerative, vascularization, signal characteristics. The signal pattern here, confidently it tells you the benign nature, predominantly T2 hypointense, diffusion low signal. So this is the role of fibroid mapping. But not all fibroids are typical leiomyomas. And you have combinations, as we have seen in the previous cases. The fibroids can be typical with coexistent abnormalities like endometriosis. The fibroids can have varying echo patterns like degenerated leiomyomas. Then you have cellular leiomyomas which are mistaken for sarcomas, and then you have true sarcomas. So this is the range of pictures. So how are you going to define or distinguish leiomyosarcoma from a typical fibroid? Here comes the role of MRI. Multiparametric MRI will give you a fairly high accuracy rate of differentiating. And what are the characteristics, MR characteristics? Margins, signal intensity on T1 weighted, T2 weighted, diffusion with ADC. Now let us see how did it help in your clinical cases. So this was interpreted as an ovarian adnexal mass. But here, when you see, there is a submucous fibroid. I am trying to trace the uterine serosal contour. This is in continuity with the uterine serosal contour. So it's a uterine mass and not a ovarian lesion. This turned out to be adenomatoid tumor of the myometrium. And typical leiomyomas, well circumscribed, iso-intense to skeletal muscle, T2 hypo-intense. See the sharp, smooth margins. Diffusion wise, it is less than that of the endometrium. ADC dark. So this is a typical benign myoma. And this is the myoma. 33-year premenopausal, 13 into 8 centimeters, left lateral wall intramural myoma, referred for MRI in view of increased vascularity. You see increased congestion seen as a distended tortuous phlovoids across the parametrium. If you look into the signal characteristics on T2, it is bright. Not too bright, but it is bright on T2. Now go down to the diffusion weighted images. Diffusion, it is bright. The ADC is also less, 1.7 to 1.8. So it is cellular myoma in view of the other morphological characteristics of smooth margins. This was characterized as cellular myoma and not leiomyosarcoma. So this was another case which was referred in view of significant heterogeneous appearance on ultrasound for characterization. Now you see here typically T2 predominant T2 hypointense with interspersed areas of T2 hyperintensity. You look into diffusion, it is dark on diffusion and dark on ADC. So it is heterogeneous, but it is not sarcomatous. Now look into this case. 55-year-old postmenopausal woman with pain abdomen. Clinically, this patient complained of pain and diagnosed as fibroid uterus. And look into this. There is a mass which has an irregular margins. The signal intensity is hyper intense and it is grayish, powdery gray on T2 weighted. On T1 it is brighter than skeletal muscle. Look into the diffusion characteristics. It is bright, significantly bright, and ADC value significantly dark, and features of internal hemorrhage. So these are multiparametric MR characteristics of sarcomatous changes. And similarly, look into the T2 hyperintense, irregular margins, diffusion bright, and ADC low. So these are the sarcomatous changes. So this is how you can distinguish fibroids from atypical fibroids and sarcomas. Coming to the second entity, adenomyosis. Adenomyosis is the presence of functioning endometrium or endometrium-like structures in the myometrium. That is presence of ectopic endometrium within the myometrium and secondary sequelae of those ectopic endometrium as hypertrophied myometrium. These are all the sequelae. The target of treatment is clinical symptoms of dysmenorrhea, menorrhagia, chronic pelvic pain. But imaging wise, the traditional teaching of direct invasion of endometrium into myometrium is not verifiable in all the cases of phenotypes of imaging what you see. So what is crux is the features of uterine zonal anatomy, which can be seen on ultrasound as well, which plays a pivotal role in modern diagnosis of adenomyosis. So here we'll look into the cases of the first case. This is the uterus, anteverted, outer serosal contour is sharp and clear. This is the cervix, external os, internal os. This is the endometrial cavity. Now look into the borders of the endometrial cavity. It is irregular. Now characterize the irregularity better. It is the irregularity is characterized as presence of cystic changes within the junctional zone with irregular border of the junctional zone. So this is typical intrinsic diffuse adenomyosis where the pathology is epicentered in the center, from inside out pathology. Outer serosa is clear, so the entire junctional zone is irregular. You do a sweep on an axial imaging and you can confirm the same. Irregular junctional zone with presence of cysts in the subendometrial zone. Now coming to the next case here. Here the outer serosa is clear, anterior uterine endometrial cavity margin is clear, but posterior cavity is all ill-defined with significant speckling and shadowing. So this is a posterior wall adenomyosis. So what does imaging give you? Imaging aids to subcategorize the morphology of the adenomyosis based on the geographic pattern of involvement and its relationship to structural components of the uterus, that is the endometrium, junctional zone, myometrium and serosa. Why is it important? Because from a clinical point of view, if you look into the subtype A or intrinsic diffuse adenomyosis, here the pathology is epicentered. It's not coming well. Here the pathology is epicentered into the junctional zone inside out and it will be central in nature. It is the most common type of adenomyosis which you see. Based on the extent of the involvement of the uterine geographic pattern, it can be categorized into A, B and C. A is focal adenomyosis, which can be anterior hemisphere or posterior hemisphere involvement. That is focal, but the pathology is inside out. Focal intrinsic adenomyosis. The outer serosa is clear and sharp. Contrary to this, the subtype 1C is mixed indeterminate with intrinsic diffuse adenomyosis and concomitant pelvic endometriosis. Like this is an intrinsic diffuse adenomyosis with presence of concomitant chocolate cyst, pelvic endometriosis. Coming to subcategory 2 or extrinsic adenomyosis, if you look into this adenomyosis, here the pathology is predominantly epicentered outside along the serosa. It is a transserosal myometrial mass with sparing of the junctional zone and a focal hypertrophied myometrial mass. This is a phenotypic representation of deep endometriosis, focal adenomyosis of outer myometrium. This is an outside in pathology. Then the third type, what you see here, and this form has got typical features of concomitant pelvic endometriosis in the form of adhesions, tethering, POD, obliteration. And the third type is no relationship to junctional zone or to serosa. These are presenting as intramural or intramyometrial masses. The age group is youngest. They present with severe dysmenorrhea, lateralized to one side to the site of clinical. These are diagnosed as ACUMs, juvenile cystic adenomyomas. But if you look into the phenotype, they have no direct relationship to the structural components of the uterus. Outside serosa is clear, the endometrial margin is normal, the junctional zone is irregular. So they represent the presence of ectopic endometrial rests within the myometrium. So this is type 3 or the third pattern of phenotypic manifestation of so-called adenomyosis. So this is what is called as ACUM. They represent cystic fluid filled structure within the confines of the uterine serosa and they can be confirmed on MRI by their blood signal characteristics. Now type 4 is the earliest which needs an eye to pick up and you are the direct target to the patients. Any patient with severe dysmenorrhea more than 7/10, image the anatomy very clearly because they present only with junctional zone thickening. Except junctional zone thickening, the uterine size is normal, the serosa is clear, there are no frank evident features of adenomyosis as yet. So this is central pattern or diffuse junctional zone thickening. Now this case, this was 28-year dysmenorrhea, chronic left-sided pain. Imaging workup done multiple places, multiple times. Multiple surgeries were done. Lap endometriosis excision was done. After that, the patient conceived. But she has persistent left lower abdominal pain. Now you look into this, they have put Marina also. Now you look into this uterus, there is a focal abnormality. Now you zoom in and look into the focal abnormality. Are you able to define a capsule? No. Are you seeing an edge shadow? No. You are seeing internal patchy ecotexture, no circumferential flow. So the pattern recognition of this was looking like a focal adenomyotic area in the left-sided lower zone. But because it was not so clearly delineatable with respect to the junctional zone here, we asked for an MRI, and look here what it turned out to be. It was an intrinsic significant junctional zone thickening with leading to junctional zone focal adenomyosis, and when this was excised, the patient was absolutely symptom free. So that is the significance of putting imaging findings in clinical perspective. Identify, detect, distinguish, and then diagnose. So take home message is ultrasonography is the first imaging technique for assessing myometrium and requires findings to be reported consistently. For that you need to really practice the terms, definitions and terminology. Images of normal or pathological myometrium or uterine masses. You should not stop with one imaging modality if the information is not complete anatomical information and requires certain times additional imaging and biochemical tests as we have seen. Put these findings in clinical perspective to generate a clinically relevant report, thereby triaging patient for an appropriate management. Thank you.